Professor Gupta, to you first. You sparked quite a reaction in the scientific community when you wrote this letter this week with other scientists too, arguing that COVID restrictions should be targeted at the most vulnerable. What exactly is the argument there?
The argument there is that the best way we can protect lives, both of those who are vulnerable to COVID and those who are vulnerable to the measures that we're taking to protect ourselves from COVID, is by allowing the infection to spread among those who are not vulnerable, such that immunity is built up in the population, which then brings the risk of infection down, let's say by Christmas, for example, to those who are vulnerable to COVID. And in the process, during that period when immunity is going to be built up, and we don't know how much immunity we need to build up, we've previously suggested that there is already substantial amounts of immunity in the population. But, you know, we don't know that. But if we take the view that, okay, we don't know how much immunity there is, but we do know that we can build up enough immunity to keep the risks low. So why not go ahead and do that, and meanwhile aggressively shield the vulnerable population?
I guess one of the questions would be how easy or desirable it would be to shield the vulnerable for the amount of time you're talking about. It could be millions of people. Professor Riley, what's your view on the ideas put forward by Professor Gupta there?
So Professor Gupta's raised three different issues there, which I think we should make sure that we get through in the time available. We talked about the existing immunity, how long it might take if we did go for some kind of population immunity strategy. She's also talked about whether shielding is effective. I think the first thing that I would really like to deal with is whether we know how much immunity or not there is in the UK. And we really do. So we've got very good sero surveys that have measured the national prevalence for England at 13% and for London at 6%. And we use very similar techniques there to techniques that have just been used in Brazil in places that probably have achieved population immunity and have had a terrible time in that process. And with very similar techniques, they measure 60%. So we've got 6%. And in communities, London has 13%, and in communities in Brazil that have probably achieved population immunity, they are at 60%.
OK, let's go back to Professor Gupta, because you obviously did the study, didn't you, in March, suggesting that half of people in the UK may have already had COVID. I mean, that's now thought to be quite wrong, isn't it? I mean, do you have concerns about the levels of immunity needed?
I think that, first of all, I should say that we do not know what level of immunity we have in the population. As someone whose laboratory has produced one of the tests that we've been using to assess the seroprevalence of COVID, I think I can say that we've been through a long journey here. And what we know, first of all, there are two things to be said here. One is that antibody levels fall. So we can't tell from antibody seroprevalence what proportion are immune. Antibodies aren't made by everybody. The levels fall. Some people are protected because they already have immunity in place, either through previous exposure to COVID or for other reasons. We know now that the picture is much more complex. So we don't know. We cannot tell from seroprevalence what proportion of the population has been exposed. Certainly not if they've been exposed 6 months beforehand. That is already clear. Basic population epidemiology tells you that even if the herd immunity threshold is low, in the first peak you will have a significant overshoot. So the idea that 60%, measures of 60% or many other measures of that ilk that are being found in, for example, Dharavi and slums of Bombay, in various settings, do not indicate that the herd immunity threshold is 60%. That is simply not true.
OK, clearly some disagreement there about the levels of immunity. Professor Riley, I guess some of people's arguments would be that there is a cost of lockdown that needs to be calculated and really brought into how we decide to tackle the virus going forward. Are you concerned that there may be a point when actually the costs of the restrictions, whether it is people not coming forward to the NHS as they want to, or people's mental health, may outweigh the cost of suppressing the virus in the way that we are?
Absolutely, and not for a moment do I believe there are any easy decisions at the moment? It's a very difficult time. I have to pick up one more point from Professor Gupta. We have to stop saying herd immunity. It's population immunity. We have to be really clear about that. That is occurring at places in the world. They have population immunity. This is being presented as a choice between a very difficult lockdown and a rapid return to relatively normal life with some extra deaths. I don't believe that's a reasonable representation of the choice. What we have is a choice between us deciding to reduce our social contacts so that this does not spread as quickly, or the virus will decide it for us. The lockdown was especially difficult in the UK because we had the virus and the lockdown. So we were scared of the virus and we couldn't go out because we were scared of the virus and we were being asked to lock down. Right now, levels of fear about the virus are lower because we've kept it low during the summer. If we don't reduce the number of social contacts, in a very short period of time, we're going to be dealing with restrictive measures and we're going to be dealing with much higher levels of fear about the virus.
And Professor Gupta, do you think that is, a fair argument that actually we all need to start reducing our social contacts in order to get the virus under control?
No, I don't think so. I think we need a sensible discussion about this because, what our common goal is to protect the vulnerables. We know that. And what we're talking about here is the most efficient way to do that. And that obviously will involve some level of social distancing. It's a question of how to apportion that in the population and whether we can have an age stratified strategy really to achieve what I'm sure is a common goal. So, I agree, I think, with a lot of what Stephen is saying in that, maybe we should avoid terms like herd immunity and we should think very carefully about what sort of social distancing measures we need in place, who to distance, how to distance them. And what really we're calling for is an open discussion, because I know that, Stephen and I want the same thing. We're coming at it from different viewpoints, and what we need to do is sit around the table and have a discussion, a really open discussion about how we can get there. Let's look at the costs of lockdown, let's look at the various costs of social distancing and come up with an optimal strategy. That's all we're arguing for. It's not a matter of being right or wrong or our scientific reputations. I think we're long past that. What we really want to do right now is to prevent a situation whereby students are locked up in university halls. That's all we want to prevent. I'm sure we all have the same goal there. But I think that an efficient solution would be to protect the vulnerable. So to put efforts into sealing off, well, not sealing off, but finding a way for people in care homes to not be infected. So we can obviously go out and test people who are coming to the care homes. While you visit someone as frail and elderly as that, you might take really serious precautions. But in the meantime, I think we can allow children to go to school without any restrictions, universities to go back, and for halls not to shut down just because there's been an outbreak amongst a group of people who aren't at risk. I think as a university teacher, I am prepared to take what little risk there is, additional risk to my life, to go out and teach students face-to-face. I think we should be prepared to do that. So but having said that, I don't want an 85-year-old to succumb to this disease. So the question is, how do we optimize given the landscape of risks that we're now slowly starting to understand a little better, and the costs of lockdown, which, lockdown is destructive. We have to accept that. And then the conversation can continue.
I think you're absolutely right to underline the point that all anyone wants is to try and find the best way of suppressing the virus, the best way of going forward as well. And it's good to have an open discussion on the programme this morning too. Professor Riley, do you think it's realistic, this idea that you could effectively segregate the population and keep the most vulnerable shielded?
I think there's two slightly different issues here. We need to do the very best job we can to shield the most vulnerable, regardless of the rest of the policy. That's an independent problem. We need to be testing as frequently as possible in care home workers and healthcare staff. I absolutely agree with that. But no, 18% of the UK population is over the age of 65. If they're going to have some contacts, there's going to be a layer of younger people and other high-risk people outside of them. We're up to a really big proportion of the UK population. It doesn't make sense in two ways. It's such a large proportion that effectively, getting towards half of us are going to be locked down anyway. So we're trying to live in a kind of bipartite way, and then it's so difficult. It's not going to be quick. If we were to adopt an entirely liberal approach and let the virus decide our social structure, it's not going to be a very rapid thing. It's going to last for a long time. And I think I agree with Sunetra that we need a really open debate about this. And the people that are recommending that we don't agree our social context for ourselves, the people who are agreeing that we just let people make individual decisions, they need to be really clear about how long they expect there to be a high number of deaths per day, what they expect the number of deaths per day to reach. And they need to be clear about how full intensive care units are going to be for how long, so people will know how they're going to feel about their healthcare service. I totally agree we need an open debate, but we need both sides to be very clear about what they believe the implications will be of the different choices.
Well, let's put that to Professor Gupta, shall we? How long do you think the strategy could go on for? How long would people have to shield for, and what kind of rate of deaths would you expect to see?
That's absolutely the right point. Is that I think one has to take on board this is not permanent. This is a temporary solution. I mean, a temporary measure that we need to make to effect a permanent solution. So between now and Christmas, if we try and think very carefully about how we can protect the people who are actually vulnerable to death from infection, and in the meantime allow those who are not vulnerable to mix, particularly in a university setting, which is effectively, somewhat sealed off from the general population, at least in my own university experience. I think we can come up with strategies. We need to, exactly as Stephen says, sit down and think about this. And this is not about liberalism. This is not a liberal. The notion that what I'm proposing is a sort of libertarian position is really, to me, very, very upsetting. I don't think that's the case at all. I think that this is this is what a welfare state should consider. We need to protect everybody, including those who are vulnerable to lockdown, who are the poor, the disadvantaged, the young. That has to be, I think, our priority. And then, with that in mind, I think we can construct strategies where we introduce social distancing, which is commensurate with their risk, for the proportion of the population above the age of 65. That's fine.
I'm going to have to come in because I'm keen to go back to Professor Riley before we have to leave it there. What's any reaction to what Professor Gupta was saying? And also, of course, there is, as we were saying, a cost to restrictions too. How long do you expect the restrictions to have to go on for until we might start to see some light at the end of the tunnel?
I think, firstly, I think while Professor Gupta may not be and thinking about this in a kind of libertarian framework, I think our experience from observing around the world is that is a large part of the debate in many places. And I think that the strategy that's being outlined for probably the next 6 months is that we have to learn the most effective ways of keeping transmission down to low levels whilst keeping schools open. So I think most people who are imagining how these are going to pan out in the future are seeing a 6-month time horizon within which we have the possibility, but by no means the guarantee, of some support from a vaccine. But it is very reasonable to expect massively improved testing over that timeline. And then some of the statistics that have been mentioned earlier in the show today, statistics about household isolation not being effective. When we have very high volume, very rapid testing, those basic building blocks of public health for infectious diseases get much, much more effective. So there are a number of things that we expect to improve substantially in the next 6 months.